Greetings, everyone. This is Eric Laser, and welcome to Bright Spots in Healthcare, produced by Shared Purpose Connect. Each episode, we bring leaders together to not only inform our audience, but also unearth bright spots, successes at health plans, hospitals, and other various healthcare organizations around the country. Our goal is to identify as many bright spots as possible so that you can determine if the ideas shared on this episode can be applied at your organization. We believe that this approach of finding a bright spot and cloning it is the most effective strategy to improving healthcare in our lifetime. The title of today's episode is How to Conquer the Transition of Care Journey. And we have the perfect partner and sponsor for today's show. They are none other than Dina powers the future of home-based care with its care at home platform and network that can activate and coordinate multiple home-based service providers, engage patients directly, and unlock timely home-based insights that increase healthy days at home. So important. Dina works with many leading healthcare systems, ACOs, and health plans to extend their reach to the home to help people live their very best lives. The platform creates a virtual experience for the entire healthcare team so they can communicate with each other and help patients and families stay connected. And even though they may not physically be under the same roof, Dina helps professional and family caregivers capture rich data from the home using AI to recommend evidence-based non-medical interventions. If your organization wants to make it safe, easy, and convenient to deliver services to consumers in the comfort of their own home, I recommend reaching out to our friends at Dina. You could find them at www.dinacare.com. Let me spell that for you, DINAcare.com. And our guest today is none other, the CEO of Dina, Ashish Shah. He leads Dina's team on its mission in the healthcare industry to transition to virtual and home care. He founded the organization back in 2015. We'll talk about why he did that later on. And he remains passionate about empowering care teams with the tools they need to help people age in place. He's a recognized leader in the industry. He actually served as Chief Technology Officer at Medicity. You may remember them. They were an Aetna company acquired in 2011. They were the market leader for vendor-neutral health information exchange solutions. So Ashish, welcome to the show.
Thanks, Eric. Really appreciate it.
Yeah, I know. So Ashish and I have gotten to know each other over the past 6-8 months. We've broken bread together. He's a terrific guy. We've had a lot of great conversations. So I'm really excited to bring some of those conversations to light for everyone, because I know you have a lot of good ideas and examples to share to our audience. I want to start, though, and just set the stage and talk a little bit about why transition of care is so challenging, specifically why returning people to the home safely is so difficult. So can you provide an outline of why that's such a challenge for everyone?
Yeah, thanks, Eric, again, and to the audience for taking the time for today's discussion. This is a really important topic. You know, I think, especially coming out of COVID, I think it's become really clear that people want to be able to have control of their overall healthcare experience. And a lot of that centers in and around their home. And so unfortunately, when people end up in a hospital, returning home is, I think, easier said than done. And some of the challenges with that could be everything from who's a high quality provider, what are my personal patient and family preferences to figure out what I should land next. Perhaps maybe I require physical therapy, perhaps I need some care or support in the home. The logistics around this can be oftentimes clumsy. And on top of that, trying to find real-time availability information around who can actually see me in a timely manner when I'm most vulnerable coming out of a hospital is something that unfortunately just has a lot of challenges. And the care at home that you may receive from a physician or a nurse or a therapist is just one part of what's required. Sometimes there may be support required around nutrition, transportation, durable medical equipment, trying to get all of that to work together in a seamless manner, much like you would expect in a hospital or a facility-based setting. Again, is just easier said than done. So this is a really important topic. Transitions of care are not anything new in the industry, but unfortunately, the need to improve them and make it work on behalf of the patient and family is something that I think we still have a lot of room to improve that process.
All right, let me see if I could summarize some of that, because there's a lot of at least good insights on an outline there. So availability, you called it real-time availability of facilities, services in general, we don't do a really good job of. The quality of said facilities and services and making sure we get them to the right places, we don't do a really good job on. Ongoing support and coordination of care, I think it's well documented that we don't do a really good job on. So I imagine that the handoff's a challenge. And what about just the decision-making process, the decision support? That seems to be lacking too.
Yeah, and there's a few key decisions. So, one decision is, again, what are the patient and family's preferences, and how do you get them involved in a shared decision-making process? To date, that's not something that is done in a high-quality manner where information and education is being shared, where you feel like you have control over that decision. The second sort of decision is around insurance. And so who has coverage and availability and authorization, and do I actually have the supporting documentation that says, you know what, I am going to need 2 weeks of physical therapy in my home as an alternative to staying in the hospital for another week or two. And so these are a couple of areas where, unfortunately, decision-making can be challenging, not really data-driven, or one that involves patients and families in the process.
Let's talk about, let's just right into an example. Like what would be an example of an exceptional process for returning people safely to homes? Because I think everyone sitting listening in healthcare, maybe they work for an ACO, they know what a decent process is, maybe probably know what a bad process is, but let's define an exceptional one for everyone.
Yeah. Well, and then I'm going to break this into two parts. The first part is a patient's been hospitalized. Paul Diaz, he can be our illustrative patient. He's spent a week and a half in the hospital, recently had a hip replacement, needs to go home to continue his rehab. He's going to need durable medical equipment. He's going to need transportation support. He's going to need healthy meals delivered. Doesn't have anyone at home to help him. This is a complicated scenario, but unfortunately not unique. This happens all the time. And so an example of a really great process is being able to involve Paul in that decision-making process around his personal preferences, getting all the documentation coordinated, exchange with his health insurance organization.
How do we get Paul involved in a very cohesive, effective manner before we move off that?
Yeah, so I think there's a lot of conversation that may happen in the bedside. And maybe, although Paul in this particular case doesn't have anyone at home, he has an adult child who lives in a different state. And so one thing that we facilitate is seamless and effective communication with Paul if he chooses to have it, or his adult child, where the options are delivered to him through very basic technology, mobile technology, where they could understand the options and choices available to them, mark their preferences, and have that information go back to the professional care team inside of a health system. That's just one illustrative example of being able to engage both Paul, but also, somebody who supports him, but may not be geographically in his home.
And also document it, because if I'm in the hospital, I'm getting overwhelmed with all the different things going on, I may not even remember some of the things we talked about.
Yeah, and especially in this case, Paul is a Medicare beneficiary. So there is a CMS mandate to involve patients and families in this process now. But we need to think beyond the printed PDF lists that get handed to patients that really are stale and can't really bring the decision or the choice to life. So again, there's many parts to this process, but this is one in particular where the family's included. Now, Eric, once that Paul has made a choice with his family, the next part is, and in particular today, being able to figure out who can actually come see Paul within that 24 to 48 hour period when he goes back home is a real big challenge. Staffing and availability is something that is pervasive, big problem across the industry. One of the things that a great process does is it unlocks real-time availability data, almost like an open table-like experience for restaurants, if you will, to say who has the availability where we can book and schedule that service to come out into your home. Today, I can't tell you how big of a problem this is across the entire industry, and it's creating massive problems. Hospitals are backing up in their emergency departments in hospitals because they can't safely get people back to home. So a great process involves the patient family, involves the home-based providers to have them share their real-time availability information, and then closes the loop. It doesn't end there, but ensures that the safe landing takes place. So patients able to graduate from that hospital room through that process, ultimately arrive at home, and then all the support services actually get activated. This is something that when it's done really well, the hospital care coordinator is saying, oh, I usually don't know how the story ends. We're changing it to the hospital coordinator understanding exactly what's happening in that transition period. And then once they're at home, how they're doing over the next 30 to 60 days as well.
So we got the decision-making down. You mentioned real-time availability for providers. I'm assuming when you say providers, you don't mean just clinical providers, but you also mean social determinant providers like the transportation, the DME providers for the durable medical equipment, PT, all of that. And then you talked about safe landing. Now, I can, in my mind's eye, I haven't what it means for a safe landing to get let's say my father back to home. But can you talk to me about what you mean by safe landing and how to get there?
Yeah. So safe landing is just like there was shared decision making of that discussion at bedside of what the plan was going to look like and who potentially is going to support you. It's maintaining connection, Eric, with the actual individual and that family to understand here's the 5-step plan to your recovery and making sure that there's good, timely engagement and communication. The data out there is overwhelming that a majority of complications, readmissions, tragic outcomes happen within the first 7 days post-hospitalization. And in particular, those first 72 hours are really vulnerable. So front-loading your engagement, making sure all the services are activated and coordinated. And if they're going to be late for some reason, making sure there's proactive communication in that really time-sensitive period is incredibly important to a safe landing. When that's done, you kind of set yourself up for a really great journey. Now, you're not done often, but it really puts you in a solid footing for a really good outcome.
So this Paul Diaz story, I'm assuming this is based upon a real example you have in your mind's eye with the ACO or integrated delivery system who's doing this. Could you just quickly take the Paul story? I think we were all experiencing that almost from Paul's perspective or Paul caregiver. What does it feel like if I'm working at the hospital and now I'm helping discharge Paul Diaz? I'm taking on risk on Paul because of an ACO, it's an MA contract. Help me view this from the perspective of the ACO, and what does it feel like for me as someone who's leading the ACO efforts?
Yeah, so I think if you're an ACO or a health system operator, you're thinking about a few things. One, how do you manage that total cost of care with the very best outcomes? So that site of care selection, that decision-making process of who should go where and for how long. Should they go to a skilled nursing facility, outpatient rehab, or have home health support? There's a lot of variability in that decision. So trying to get that decision to be as evidence-based as possible is something that they're thinking about, and it can definitely move the needle in terms of total cost of care.
And how do I do that? And sorry, how do I do that? I'm really busy. I'm overloaded with patients. How am I doing that really effectively or much better than I am today?
Yeah, I think the first is you're leveraging data. And so you're leveraging data that's coming back from the patient family in terms of their ability and their preferences, but you're also reviewing things like functional status documentation and notes inside of the hospitals, other indications that are going to tell you whether somebody should go to one particular care setting with the service or another. Again, a lot of variability in this particular area. Getting this decision right is a documented approach to really delivering total cost of care in an ACO environment. That's the first part, Eric. The second part.
I have one more follow-up because I think this is really important. I want people, and I know we're trying not to make this a commercial, Ashish, but when we're talking about the real-time availability, and remember from the hospital perspective, and you're providing a dashboard linked in with that's connected to data sources that most hospitals don't have access to. Help me explain. Help me understand that real fast.
Yeah. Well, the first piece is we're sourcing data directly from partners outside of that hospital system. So like you mentioned, could be community-based organizations who offer behavioral health program and trying to figure out who has the availability to take a patient. Could be skilled nursing facilities trying to figure out who has an available bed for a step down scenario, or home health organizations and trying to determine whether they can open care within 24 to 48 hours. So the first thing is we're sourcing that data, but we're injecting it right into workflow, embedded inside of the EMR experience. So you're making the care coordinator's life incredibly easy by taking something that's a process littered with a lot of phone calls, paper, just a very disjointed process, and turning it into something that is a very seamless, modern, contemporary day experience. Operationally, when this process doesn't run well, regardless of value-based healthcare, this creates challenges around uncompensated care or avoidable days. So when somebody's ready to leave the hospital, but they can't find the next available spot for that safe landing, hospitals on average have to write down or write off anywhere between $500 to $2,000 per patient per day. This is a pretty important metric. And so you're seeing communities, unfortunately right now, because of the challenges around staffing and supply chain, where they can't get patients safely back to home, it's really creating some financial pain. So fee-for-service mindset, you got a problem. In a value-based care construct, you also have a big problem. That decision point of what they utilize is going to drive total cost of care. So you kind of need both. And of course, you need great outcomes regardless of which payment model you're pursuing.
And so getting past, because you want getting past real-time availability, you're going to mention some other things from the hospital perspective. I don't know if you were going down the decision-making part or the safe landing part, but
yeah. Well, I think we think about this in a two-part process. The first is how do you get them safely home? We've spent a lot of time on that already. The second part is how do you maintain connection? And so if you're taking some form of risk, your ability to maintain connection with that patient and family on their overall healthcare recovery is mission critical to population health initiatives. And, one of the bright spots that we've been unlocking in the Northeast with a really well-reputable health plan and provider organization is the ability that once care is transitioned back into the home and community, being able to take traditional community-based organizations and home care organizations and beyond delivering the care in the home, turn them into advanced data collectors that surface functional, behavioral, and social determinants of health needs that are driving down unnecessary hospitalizations and ER visits, but also for those who are senior in nature, slowing that progression to long-term nursing home care. That is something that we're going to need to do more and more of, especially as 10,000 people turn 65 years old a day. So the ability to kind of create greater visibility into what's happening in people's homes through these mechanisms has been something that we've seen quite successful in the market.
So I want to go to like creating a blueprint or a framework on how ACOs and hospital systems can create an exceptional transition in the whole program. I think that's really important for everyone to understand. But before we go there, I want to take a step back. You are the founder of Dina. Like, where did this come from? What inspired you to start this company?
Yeah, well, I appreciate you asking that. And just to clarify for the audience, I do have a co-founder, a really impressive gentleman by the name of David Coyle. The two of us have known each other for a very long time, and we teamed together at Medicity. But, and I'll share why, in particular around Dina, beyond our personal relationship, he struggled with some of the same problems that I did personally, which led to the formation of the business. Shortly after my previous company, Medicity, was acquired by Aetna, my father suddenly passed away. Unfortunately, this is something that you hear a lot in healthcare ventures. There's often a personal connection. And in my case, I'm trying to solve a problem that our family experienced. But my dad was a senior citizen. He was being seen by in-home caregivers and in and out of senior centers. And after he passed, unexpectedly, we spent time with those folks, and we saw that they saw a meaningful decline coming. And yet that information wasn't being shared with the formal healthcare team, definitely not his insurance company, and not with his family in a way that we could intervene and try to change his care trajectory. I took that experience, and obviously it was a very difficult experience for the family, but I'm sitting inside of a large healthcare organization as an executive. At Medici, we're serving 1,300 hospitals, facilitating lots of data exchange across hospitals, primary care, and lab. But nothing we were doing was ever going to touch the home and community. And as I dug into it more and more, I found that my story, unfortunately, is not unique. It's going to be one that grows in nature. And so, both out of professional and personal need, I called up David, and we were able to team back up to really look for an opportunity to organize this home and community-based care ecosystem and make it easier for health systems, ACOs, health plans to really extend their reach and visibility into the home in an effort to help people maximize their healthy days at home. So we launched a business in 2015, and we've been very focused and committed to bring the vision to life.
That's great. Well, congratulations on that. Yeah, I mean, it's interesting how we go to another level when we get emotionally inspired by the ones we love. So that's a great story. Thank you for sharing it. Let's now take it to let's get into the sort of business components of this. Mm-hmm. And always a weird transition, but let's get into so if folks who are listening to this and getting excited or inspired or both, how do we let's blueprint it for them? How do we build this kind of program?
Yeah, there's when we first started the business, Eric, we would tell people what we're trying to do, and we get a lot of head nods, and they'd often share a personal story that they have around why this is a process that can be much improved. However, coming out of COVID, I think everyone realizes that care is going to be delivered in three ways. It's going to happen in high quality facilities. It's going to happen online with telehealth type of capabilities. And the third way is it's going to be brought to you in your living room. And it's that third particular component that we're really trying to organize and make a viable option at scale in the industry. And so we talked to the market a lot about implementing a care traffic control model. And what I mean by that is, if you're a traditional healthcare organization, health system provider organization, or a health plan, setting up the infrastructure to really be able to activate, track, and manage care outside of the traditional four walls of a hospital, for example. And so what do you need to do to bring that to life? The blueprint for us really has multiple steps to it. But the first is really looking at your existing network of partners outside of the hospital. That could be ambulatory, post-acute, community. But there's an opportunity to digitize that ecosystem so you can seamlessly interact with them, but also extend it. So a typical organization may have relationships with skilled nursing facilities and home care organizations, but they don't yet have formalized relationships with meal delivery, transport, courier services, mobile imaging and lab systems. And so really expanding your post-acute network from what we call a 1.0 to a 2.0 model that has a more diverse set of services is really the first step in the blueprint. That yields results right away. When you put that in place, being able to streamline that journey from hospital to home moves the needle on core KPIs like uncompensated care and avoidable days. That pays for itself. Now, once you have that in place, you can start to do some really great things. Virtual care, I think really came to the rescue in a big way during COVID, but whether that's remote patient monitoring or telehealth encounters, most systems have started to make an investment in both of those. Taking that and integrating it with your post-acute network is what I would say is sort of the second major component here in ensuring that you have safe landings back into the home and then ongoing monitoring and instrumentation. When you have these two pieces in place, you're now in a position to start to tackle new care delivery innovation. And what I mean by that is, could be hospital at home, could be skilled nursing facility care at home, or chronic condition management at home. But new emerging care delivery models can now be powered when you have your resource of partners in a digital network where you can collaborate in real time and your virtual care assets integrated into it. And that's really where we see the market moving in terms of care traffic control ultimately. So start by better organizing your post-acute. Secondly, start to think about integrating your existing virtual care assets or your recently selected ones. And third, packaging them to really start to deliver care in a new and meaningful way.
I like it. So the looking at the post-acute seems to be a huge lift, right? Because you have to find the mail deliveries, the CBOs, the transportation, the labs, you mentioned all those that are not traditionally in the toolbox for the hospital. The integrating, the second point, I just want to make sure I put a bow on it. It's integrating virtual care in real time with subacute facilities.
Yeah, or in the experience. So coming back to the safe landing example, transitioning care and activating a home care service when somebody leaves a hospital is great, but we now have the ability to remotely monitor people in between physical encounters and visits. And if we detect an abnormality based on a signal coming back, being able to coordinate or schedule a just-in-time telehealth encounter is something that's available to us. It's something that's actually alleviating a lot of pressure as it relates to staffing across the care continuum right now. So thinking about the two, not as exclusive in one mode or the other, but really thinking about them working together in concert, I think is a very important building block to moving into a new delivery model like hospital at home or skilled nursing care at home.
So the way I kind of conceptualize it is the first part of the blueprint is you need to collect and make sure you have all the resources and make sure you have resources that may be missing. Then the second is you have to write a connection, a distribution, or it's not distribution, a connection between resources and the home, so the patient and caregiver. And then the third is actually execution, hospital at home, right? Chronic care at home, skilled nursing at home. Tell me, double click on that a bit, because that almost seems in the way we're talking about it as a byproduct of doing the first two, but there's probably some inherent challenges that you help facilitate in executing all those.
Yeah, absolutely. And every organization's at a different spot. We have some that say, hey, I'm jumping to the end of that blueprint, and I've got the other pieces in place, and we're going to start delivering hospital or SNF level care at home. How do we do that? We have other organizations that say, you know what, I need to get the basics in place, but I need to be skating to where the puck is going, to use a hockey and Wayne Gretzky term. But so we see both for sure. But at the end of the day, if we roll the tape forward 5-10 years, most organizations are going to have to do all of it. And so I think what the market, based on our feedback and interactions, is people are looking for a platform level approach. That's the convergence of post-acute, transitions of care, network management, paired with virtual care and analytics to really set them up. Right now, there's a lot of individual niche solutions, which are great, but having them all work together in a smarter way is what most organizations need moving forward.
And as you have built this, and if folks are going to try to build this on their own, I know you spent a lot of time understanding the journey of an individual as they went through their final days in the hospital, moved out of the hospital, went to an interim location, maybe a second interim location, then to home. So tell us a little bit about journey mapping and how that is incorporated into everything you've built.
It's so happy that you asked that question. I mean, in the early days, we didn't really promote ourselves. We didn't, have a website. We didn't do anything. And a lot of the early work was actually just embedding ourselves deeply into the care delivery experience and administrative and operational workflows. We were far from home care experts, or we didn't really understand that particular market. So we would go visit branch locations. We would watch people work. We would sit next to them in their computers, watch how they would communicate and make phone calls. This is critical. And I would say this, the great ones, I think, really commit to this on an ongoing basis of staying connected to the person and the people in the organization that you're trying to help. Not trying to use it as a training session and promote your point of view, but really just sit there, observe, and do the ethnographic research to understand what it takes to understand their problem, but then try to help move the needle in a positive direction. We did an overwhelming amount of that in the early days. And as we've scaled and have access to more resources, we continue to do that. Now, there are times where we may get away from it a little bit, but our organization is happiest when we're deeply connected in that manner. So journey mapping to me is table stakes. And it's not a one and done scenario. You kind of need to consistently stay on top of it, because once you unlock one bottleneck or two, there's usually others. And, we're all in healthcare trying to do the right thing. There's an overwhelming number of problems to solve to make the entire experience better.
So my guess is you have more confidence in your ability to journey map than many other organizations out there, and probably everyone's doing it. Is there anything about your approach to journey mapping, what you have learned with Dina, that you could provide some insights for everyone else to make them better at journey mapping?
Yeah, I think there are probably two things that stand out right now, Eric. And, there are some organizations that do a great job with this, but in terms of our experience, the first is you have to be embedded in the customer's environment or the user's environment. So that doesn't mean going to their site and sitting in a conference room. It means being embedded and immersed in their actual operating environment. Is the first thing that I would say, just to have a good appreciation and visual of what they're dealing with on a day-to-day basis. The second, and this is really hard, it's very hard for me personally, but it's to listen and observe more than we speak. A very successful experience here could be 90% observation and 10% dialogue. But I think the amount that we can learn by watching what people do versus asking them in an interview format is from our experience, been a big differentiator. I think you can learn a lot by what people do versus what they say. So these are two things that I'd really emphasize to anyone who's going down this journey.
So let's bring it back to the business. So if I'm a CEO of a hospital or ACO, I'm already playing around with some basic risk-based contracts. I'm already stratifying my patient population. Maybe I'm doing some PGs. I've got some SLAs, and maybe I'm even taking on a little bit of risk. But to really become confident in value-based contracting and maybe doing a total cost of care risk arrangement, which has the most upside, you really have to have your transition of care process, tested and optimized. So can you talk a little bit about how to take advantage of value-based care as a business opportunity and tie it to what we're talking about today with transition of care?
Yeah. I'm glad that you mentioned some of the existing investments that have already been made by provider organizations or ACOs, because there are great ones. It could be their EMR. It could be a risk stratification engine or analytics. Maybe they're getting care notifications when people move across the continuum. So let's assume that the majority of the market has that in place. I think what's next, and to truly do a good job in terms of managing that total cost of care and maintaining high outcomes, is moving to where care is being delivered, and care is being delivered in the home increasingly. So whether it's SNF or hospital level care at home or chronic condition management at home or physician house calls, you need to move to where care is being delivered. You need to have access and visibility. And so in many ways, we talk to the market about upgrading their care management platforms, not replacing them, but upgrading and enhancing them to be more home-centered in their longitudinal care management approach. And what that means is connecting to partners that are non-traditional, home care, CBOs, et cetera, and tapping into their insights and observations, much like in my dad's case, in our postmortem scenario, get access to information that are going to surface really important insights around social, behavioral, and functional health status that really make a massive impact on outcomes. Yet those are not insights that are easily shared because those organizations haven't been involved to date. So I would say it's time to start to graduate to the next level of innovation to really deliver it. I think relying on claims data or hospital EHR data, although good, the next step is to really get to new sources of data. If you look at CMS's new strategy around promoting health equity and addressing social determinants of health, I think we would all agree that that's long overdue and makes a lot of sense. It's great to see some policy focus around it. Devil will be in the details, and it's going to be easier said than done, but nonetheless, the focus is a really good thing that should be applauded. The way that's going to be delivered is really connecting an organization's investment in population health and care management and centralized systems to the distributed nature of care in people's homes and communities. That's a lot of where things are headed, I think, over the next 5 to 10 years.
Yeah, and I know we're getting tight on time here. I want to circle back quickly to the Paul Diaz example. And my guess is, I know you probably can't mention clients by corporate name. You have a client in mind that the Paul Diaz example was born from. How could you, how is that client in a position now, or can you share at all any kind of impact that their transition of care program is making on whether it be their risk contracting or just their overall business as a whole? Is there anything you can enlighten us to on how that's working?
Maybe one of the most exciting innovations that we've been a part of. One, not only because of the solution, but the outcomes. I think we talked about driving down unnecessary ER visits by 42%, avoidable hospital readmissions by 30%, slowing that progression of long-term nursing care. That's born out of this particular example. So you have someone like Paul, who's a frequent flyer, who's going into a hospital very frequently. When his transition of care process is managed to a very high quality home-based provider, and that journey and that safe landing takes place, the ability for that home-based provider now to capture all of their observations and interactions in that home and get it back to the organization in a way to better manage that risk is cutting all of those return visits. It's creating better outcomes. It's keeping the family engaged and involved. It's saving the broader health plan money so that they can invest in better and better service and solutions. It's a winner across the board. But the innovation here is not just transitioning care and forgetting about it. It's maintaining connection and pulling back these insights around social, behavioral, and functional health in a way, and then acting on them in real time. I think it's a beautiful model of care. It's something that we're really, really passionate about, making sure that we can help promote, whether it's through us or other partners in the industry. It's where the puck is headed next.
Always ends with Wayne Gretzky. This was great, Ashish. Where can folks find you to pick your brain? I have access. It's always been great when I get to pick your brain and shoot the breeze around the industry. How can our listeners find you? LinkedIn?
Yeah, you could find me on LinkedIn under Ashish V. Shah. Dina Care Incorporated also has a presence there. You can visit our website, as you mentioned, www.dinacare.com. There's many touch points and ways to reach us. And also, I would say, I would encourage them to get in touch with you. And if you feel like there's something that we could facilitate in terms of a conversation, I think our primary focus here, Eric, is to help more people help their communities access care on their terms in their homes and maximize their healthy days at home. So whether that's through a solution like ours or other partners, I'm a firm believer in rising tide lifts all boats. So it's okay if it's not always through us, and it's in collaboration with others.
Right. Well, then we'll put your LinkedIn profile link to it within the show description so people will just see it, as well as go to Dina Care and check you out there. Thank you so much. And to our audience, as usual, I like saying, we don't take the time you spend with us lightly. We know you are very busy, and we like saying that this is your Bright Spots in Healthcare podcast. Have a great day, everyone.
Thank you.